Good evening. My name is Karen, and I'm a Community Education Coordinator for Boulder Community Health. I'd like to welcome you to tonight's lecture on relief for painful back problems. I'd like to go over the format for the lecture. The lecture portion will last about 40 minutes. Afterwards, we'll use the remaining time for questions. Please type your short, general question in the chat box below the video on your screen. We'll get to as many as we can. On behalf of Boulder Community Health, it's my pleasure to introduce this evening's speaker, Dr. Robert Harper. Dr. Robert Harper is a board-certified orthopedic surgeon with extensive fellowship training in spine surgery. Dr. Harper is highly skilled in treating a broad range of conditions in the back, neck, and spine using the latest surgical methods available. This expertise includes the latest techniques in minimally invasive spine surgery, such as image-guided and robotic spine surgery. He sees patients at Boulder Center for Orthopedics and Spine in Boulder and Broomfield. Welcome, Dr. Harper.
Thank you very much. Good evening, everybody. Sorry for my appearance today, but we were actually working today till pretty late. I'm Dr. Harper. I am an orthopedic spine surgeon. That means that I trained as an orthopedic surgeon and did specialty training in spine surgery, so I'm also trained to treat other bony conditions and fix fractures. I'm board certified by the American Academy of Orthopedic Surgery. I went to medical school at the University of Missouri in Columbia, and then I attended residency at the University of California in Davis, and then did my spine fellowship at Stanford. Tonight we're going to talk about a spectrum of back conditions that I see in the clinic and that are the most common things that I see every day. We'll talk about the various treatments that we employ for these various conditions, and that includes many conservative treatments. So most people that I see in my clinic don't get a surgery at all. And then we'll also talk about some of the surgical ways that we treat things, only because there are times in which people who come to my clinic have conditions that do require a surgery. The first topic for tonight is low back pain, which is very common. I would say 50% of the people that I see in my clinic on an average day have back pain. Back pain comes in two varieties. It's either acute or chronic. Acute meaning you went to pick up a box, you had this horrific back pain that lasted for a couple of days, and then it went away after you did some rest and put some ice on it. There's also chronic low back pain that's been lasting for several months. It really is what defines chronic pain, and some people have chronic low back pain for many years. Like I said, it's very common. It's one of the most common reasons that people go to a doctor. It's also responsible for a significant portion of economic loss in our society. Almost everybody at some point in time is going to have some low back pain. I would say the most common thing that I see in my clinic is an acute low back pain, which is people were playing golf and they developed low back pain the next day. They picked up a box and felt a twinge in their back or felt a pop, and they developed significant low back pain. The causes of this are numerous. I would say most commonly I see it's usually a muscle strain or muscle spasm. That's usually the acute low back pain that usually gets better after a couple of days. You can have degenerative disc disease, and I'll show some pictures to kind of describe that, but what it means is that over time, as we age, and through micro trauma or smoking or any other conditions, your discs will lose water, and the spring and shock absorption that they were designed for gradually diminishes in its ability to hold you up and also provide shock absorption for the spine. And when the discs degenerate, that can actually cause low back pain. Your SI joints actually are kind of right at the lower part of your back, and people that have SI joint dysfunction or SI joint arthritis can often have low back pain. Fracture, of course, and then there's a couple of conditions we'll talk about a little later called spondylolisthesis or spondylolisthesis, but also arthritis of the joints. So in your back at each level, you have two joints. So in your low back, you have 5 lumbar vertebra. That means you have 10 joints that have to move all the time. And so if any one of those gets arthritis, you can't get off your back like you can get off your knee or your ankle. And so unfortunately, as you move back and forth, that can cause back pain. Usually when people have some kind of muscle strain, that usually is kind of a center pulling type of pain in the low back. It may radiate up and down. It usually doesn't go down the legs, so it doesn't cause numbness or tingling. Arthritic pain tends to hurt most when people are extending their back or when during transitions while going from seat to stand. People that have degenerative disc disease often have more back pain when they sit for long periods of time and in fact feel better when they stand up. When I see a patient in clinic and they have low back pain, we talk a lot about what were the inciting event. Did you have a fall? Did you have some trauma? Did you have an accident? Was there something you did that may have caused it? And if there wasn't, then we talk about some of your risk factors. You know, do you sit all day? I have police officers that I take care of that wear vests and have to sit in a car all day. Or, you know, I have a chef, you know, do you work on your feet all day long? I take care of nurses. Those are people that bend over all day. And so all of these jobs there are a lot of physical jobs out there that really can play a big role in causing low back pain. So when I see a person in clinic, I usually talk to them about what was the origin of the back pain, how long has it been going on, what makes it better, what makes it worse. And then we get some imaging, and I usually just start with x-rays. And honestly, that's an excellent way to sort of evaluate low back pain because it allows me to see what your spine looks like with you standing. And I can see if you have a fracture. I can see if you have severe arthritis of the joints. I get pictures of you moving back and forth so I can see if there's some kind of instability. And then the treatment is really dependent on what I diagnose at that time. So for the average acute low back pain, what we do initially is if it's severe, what I'll do is often start with a small dose of steroids. It's called a Medrol pack. You take it over 6 days. It really works wonderfully to sort of quell the acute inflammatory portion of the low back pain. And then we often give muscle relaxers because there tends to be a muscular component. And then generally we start you in physical therapy once things have cooled. A lot of people want to know if it's ice or heat that's going to work better. I would say usually if it's an acute injury, ice is probably better to start. Heat's usually better to relieve muscle spasm. And so also using those two in conjunction with each other. Then we almost always get you into physical therapy because honestly, most of us can probably stand to work a little bit on our core. So maintaining strong core muscles, which includes like your ab muscles and your oblique muscles that work on the side, and the low back muscles. Those muscles and their support of your trunk really need almost constant attention. And as we age, or depending on what activity level you have or what you do as a profession, probably requires a little bit of maintenance every day. And NSAIDs work wonderfully to help with low back pain. So Aleve, ibuprofen, sometimes Celebrex or meloxicam. Tylenol works well in conjunction with these other things. When people have low back pain that's related to things like facet arthritis, if you've undergone physical therapy, you've taken medication, and those things have not been truly effective, there is a procedure called a radiofrequency ablation that some of you may have heard of. And it's illustrated here, and really these are the joints in the back here. And what a physiatrist can do is inject the nerve that goes to the joint, and that would disrupt the signal that goes from the joint to your brain. And so the physiatrist would inject this with local anesthetic. If you get significant back pain relief for a couple of hours, usually we'll repeat that. And then if that is effective, they can do a procedure called an ablation where they burn the nerve to the joint. It sounds pretty horrific, but it's actually a wonderful and very durable treatment for low back pain related to facet arthritis. For people that have degenerative disc disease, sometimes we try epidural steroid injections, we try physical therapy. Cognitive behavioral therapy, believe it or not, actually works pretty well for especially chronic low back pain. And then there's some other adjunctive medicines that we use, like duloxetine and some other medicines that work in conjunction to treat chronic pain. This is really never, I shouldn't say never, it's very rare for low back pain to be a surgical condition. The only times in which we discuss surgery for low back pain would be either if there's some kind of instability, and we'll talk about the sources of instability a little later in the talk. Severe chronic degenerative disc disease can actually be treated with surgery, but it's really needs to be have a very long conservative course in order to be amenable to treatment like that. And then for SI joint dysfunction, there's PT that works well for SI joint dysfunction, and you can do injections into the SI joint, which help diagnose if you're having SI joint pain. And generally, complete relief of the pain signifies that it's going to be an SI joint pathology. The next condition we'll talk about is called a herniated disc, and this is another thing that I see very commonly. So this can often start with low back pain. You may pick up a box. You may, I've seen things as ignominious as getting something from the backseat of the car or bending to get dishes out of the dishwasher. But usually it's sort of a twisting and bending, and what will happen is this is the spine here, that's L5 and that's L4, and this is the disc here. This is a cross-section of the disc, and if you bend forward with weight on the front of the spine, or if you twist, you can push the material inside of the disc out the back. So this is what a disc looks like. This is called the annulus. It's kind of a firm, fibrous exterior, but the inside is fairly gelatinous. And as we get older, that does dry up and becomes less gelatinous, but it's certainly more liquid than the outside. And as we get older, or if you have sort of chronic degenerative disc disease, or if you have other micro tears in the back of the disc, which occur just because of micro trauma or degenerative change, it can weaken the back wall of that disc. And what will happen is if you bend forward and put weight on the front of the spine, or if you twist in a certain way, you can actually push that disc material out the back, as you see here. And back here in the spine, that's the canal in which your nerves descend. So the nerves come all the way down through the spinal canal. And in the lumbar spine, you don't have a spinal cord anymore. Your spinal cord becomes a tail of nerves. We call it the cauda equina, meaning horsetail. And it's a series of nerves that exit at each level. So it's really more like a water balloon filled with your nerves. Well, the disc material squirts out the back and compresses one of these nerves, and it causes pretty horrific pain. The symptoms of a disc herniation tend to be initially low back pain is frequently how I see it start. Most of the time people can't think of any inciting event or trauma, but what will happen is you'll have pain that starts in the buttock, sometimes it starts in the hip, it often goes just down one leg, it'll shoot down the leg, down the side of the leg, the back of the leg, sometimes the front of the leg. Often it's accompanied by numbness or tingling. Disc herniations usually are worse when you sit, and they feel better when you stand and walk. So I can frequently tell somebody in my clinic who's had a disc herniation because I walk in the room, and if I'm not running late and I'm on time, then they're standing up. And so usually I can see if they have a disc herniation because that's really the only position they're comfortable in. In fact, I myself had a disc herniation and I couldn't sit down for almost a solid year. Occasionally too, if you compress the nerve enough, you can actually get weakness in the leg too. This is a picture of what we call the dermatomes of the leg. And the reason I'm bringing this up, because a patient actually brought me a picture of another talk that I did, and I thought this would be useful, is that oftentimes I can tell you where your disc herniation is before we get any kind of imaging, because the trajectory of your pain often defines what nerve root is being compressed. So we'll look at an MRI here in a moment that shows a disc herniation at L5S1. That pain tends to sit right in the sort of the crease where your buttocks meets the back of your leg, and then it'll extend down the back of the leg to the calf. And if you have a huge disc herniation, it actually will cause weakness with push-off, so it'll make it difficult to stand on your toes. L5 will often run down the side of the leg, and that actually performs dorsiflexion of your foot, which means you lift your foot up, and so people will get what's called a foot drop, usually with an L5 or sometimes an L4 disc herniation. And then as you go higher, a lot of times the pain starts running down the front of the leg. So an L3 or L2, L2-3 or L3-4 disc herniation may run down the front of the leg or in the groin. This is an MRI, and this is showing a disc herniation. So this is S1. So this is a picture looking at your spine from the side, front, back, top, and bottom. That's L5, L4, L3, L2, L1, and that's S1. And these gray, dark things are the discs in here. And this structure here is the spinal canal, and those gray things are the nerves descending through there. Well, that piece of that finger-like projection coming out of the back is a disc herniation. So this image on the right here is a cross-section through this disc here. And this is the disc here, and then this finger-like projection is extruded disc material that's come out. And it's pushing on the nerve on the side. So if you look over here, this is the S1 nerve root descending in this corner. Well, the S1 nerve root is in here somewhere, but it's being crushed by this piece of disc. So this person would have severe left leg pain. When you're looking at an MRI, you're looking at it from the bottom up. So actually, this is your left and this is your right. So a lot of times this person would likely have had, in fact, I remember this patient, they had pain down the back of the leg. So what do we do for herniated disc? Well, the good news is most of these get better on their own. So over 90% of disc herniations get better on their own. Now and People often wonder what that timeline is. I would say usually the first 6 weeks tend to be pretty rough, and if they're going to get better on their own, within 6 weeks to 8 weeks, they tend to get better quite a bit. The disc you can't push the disc material back into the disc, but what happens is if that disc material extrudes out, your body resorbs that over time. But it doesn't have to completely resorb to make your symptoms better. The disc comes out, the inflammation quells and or subsides, and a lot of times the disc starts feeling better because there is an inflammatory cascade that accompanies a disc herniation. And in fact, they did a study where they put disc material into a spinal canal and measured what are called inflammatory cytokines, which are these molecules that signify inflammation in your body. And they found all that was upregulated. So just the presence of disc in the spine, regardless of nerve compression, created inflammation. And it's not just physical compression of the nerve that causes the pain, but also the inflammatory cascade that goes along with it. And that's why people take NSAIDs and they make your leg pain way better. And so how do we start? Well, this is another thing where we get you started in physical therapy. Usually when I see an acute disc herniation in my clinic, I also use that Medrol pack that I was talking about before. Usually a quick and large burst of steroids to start quells the inflammatory cascade and gets you feeling better. I often will give muscle relaxers too. Then we get you started in PT, and one of the reasons I give those medications is a lot of times you have to get the pain better because sometimes people can barely walk, they can barely stand. A lot of times people get contracted because they can't extend their leg all the way, because when you extend your leg all the way, it causes pain down the leg. And so we just need to get that suppressed enough for you to do the exercises. And then the PT exercises, which work on nerve gliding, they work on core strengthening, they work on low back strengthening, and a little bit of time and some NSAIDs really can go a long way to helping relieve the pain of a disc herniation. If those are not effective, there's another treatment, epidural steroid injections. I'm sure most of you have either heard of them or had them yourself. And so this is just injecting steroid directly to where the disc herniation is. When I give a Medrol pack, it's more like carpet bombing an area. It's just, profound anti-inflammatory medicine being given to your entire body. Well, this is more of a precision strike where you inject steroid directly to the level and or the level below where the nerve exits with some steroid to make that nerve feel better. Those work wonderfully. And I would say most people with a course of NSAIDs, physical therapy, and some steroid injections do wonderfully and really never ever have to see me ever again. In a small group of people, you do need to perform a surgery, and so that's called a microdiscectomy. So the only time I discuss surgery right away when I meet people is if you come to clinic and you have pretty significant weakness from the disc herniation or stenosis, and that means the nerve's getting so compressed that it doesn't work so well and it's being damaged. There is a window of time at which you can observe weakness, but the longer you let weakness persist, the less likely it is to return with either time and allowing the disc to resorb, or even if you went in and took it out. So microdiscectomy is reserved for people that have tried all the conservative things and it's just not worked anymore, and they still continue to have leg pain and the injections don't work and the physical therapy is not working. Or sometimes if you have all those conditions plus you have weakness, then sometimes we discuss surgical treatment of that. And really what that involves is making a small incision in the back, making a small window in the bone right here, and then really I can move the sac of nerves aside and I can take this piece of disc out, the herniated piece out. I don't take the whole disc, I just take the herniated piece out, and that allows the nerve to then descend freely through the spine. It actually works wonderfully. I myself had a microdiscectomy, and I would say it was life-changing, honestly, because most of the time you wake up and the leg pain is gone. The numbness and tingling can persist for some time, but it usually gets better. And then generally the weakness gets better pretty fast too. For those of you that have a strong stomach, this is an actual picture of a disc herniation. This is the annulus pulposus that I took out of a patient. You can see this was a pretty darn big disc herniation and they were pretty miserable. And so you can see if that's sitting in your spinal canal, pushing on your nerve, that would be quite painful. And so for this person, it actually was quite painful. And so these are actually really satisfying surgeries to do. You just sort of puncture this little area. That disc often pops out kind of like a zit. You pull it out and the nerve gets through freely, and it's really a wonderful surgery. The next condition I was going to talk about is called lumbar stenosis, probably another condition most people have heard of before. This is a little bit different than a disc herniation in that this is narrowing, and stenosis just means narrowing of a canal. It's narrowing of the spinal canal, sort of globally or circumferentially. And different than a disc herniation, which usually causes pain on one side or the other because the disc protrudes usually to the right or to the left. This causes pain that goes down both legs. It doesn't always cause leg pain. Frequently what you'll see is people that have butt pain, buttock pain, leg pain, thigh pain, often numbness and tingling that's worse when they stand and walk. So they stand up, they walk, and this is why it's different than a disc herniation. Patients stand to walk, they get pretty significant pain in the legs. They sit down or lean forward and they feel much better. Frequently people say they can shop as long as they want because they're leaning forward on a shopping cart, and they feel much better. It doesn't always have to be pain and numbness and tingling. So people often will have a sensation of just a global sensation of weakness as soon as they stand to walk, or just a feeling of their legs are heavy or tired. And actually stenosis also, if it's high enough in the spine, say at L3-4 or even L2-3, sometimes it's only severe back pain. So people will get this severe back pain as soon as they stand up or extend their spine, and they get this horrific back and sometimes leg pain that gets better when they bend forward or sit down. This is a very common condition that I see. Here's a picture of that. So same as before, this is the spine looking from the side, front, back, and top and bottom, these being the discs. And this is the spinal canal, and those gray things are the nerves and the white stuff is the fluid. And right here, you might be able to see there's a constriction where those gray things are all bunched up. And this picture over here is a cross section through that level. And so to give you an idea of what normal looks like, over here, this is a cross section through the disc here at L3-4. And this is the front, back, right, and left. And those gray things sitting there are the nerves, and the white stuff is fluid, and see how they descend freely. Well, if you look over at this picture over here, I don't see any daylight coming through there. And that's severe central stenosis. And so this patient, same at L4-5, a lot of times people get pain really just, in the hips or the buttocks. That's worse when they walk. That gets better when they sit down. This is, again, just like any condition in spine surgery, save a few, is something that's generally well treated conservatively. As before, with a disc herniation, we treat this with physical therapy to start. So same thing with nerve glides, getting used to extending your back, getting those nerves to glide through the spinal canal effectively. A course of NSAIDs, so we'll try meloxicam, Celebrex, sometimes ibuprofen. Everybody's different for what NSAID works for them, and so sometimes it's trial and error. Sometimes people know what works for them, so we usually just have you pick the NSAID of your choice. Tylenol also works. And then epidural steroid injections also can be very effective for this. So if you inject steroid either into the center here or off to the sides in these nerve holes, steroid gets into this area and helps the leg pain feel better. Steroids don't actually shrink a disc herniation, and they don't make your spinal canal bigger, but they do quell the inflammation so that those things can start feeling better. So frequently, those are the first treatments that we go for, and frequently that's very effective for people with spinal stenosis. And I will say, because I see patients in clinic sometimes who have, stenosis on their MRI, but they don't have any symptoms. So spinal stenosis in and of itself is a thing, but it doesn't always even need treatment. So say you had an MRI that looked like this that shows severe stenosis, but you could walk as long as you want, you had no back pain, you had no leg pain, then you don't have to do anything for it. So if it's a condition that has no symptoms at all, and they have this spine, but they've had no leg pain for years, and then you look at this MRI and you know that this didn't occur yesterday, it's been slowly growing over years, and frequently people want to know, well, why now? And the short answer is things are asymptomatic until they're not, and the long answer is usually stenosis is a gradual chronic course of compression of nerves over time. So as the joints hypertrophy or get bigger because of arthritis, as the disc tends to lose height, the ligaments fold into the spinal canal, and all these things converge to squeeze the nerves in the middle. And generally your body can accommodate pretty well to compression in that respect. But what happens over time is your body's accommodated to gradual compression over time, but there is a point at which the compression is too much, and there's just, your nerves will say enough. And maybe it was one additional micron of movement or 1 millimeter of mercury of additional pressure that required the nerves that were previously not painful at all to become symptomatic. And so that's when we end up treating. And without weakness, again, this is something that I treat very conservatively. There is surgery for this, and that's reserved really for people that have tried all of these. The injections are no longer working. The physical therapy is no longer working. Rest and NSAIDs and ice and heat are no longer working. And the treatment generally for this, without any instability, is to do what's called a decompression surgery. So you make a small incision in the back, and just like a disc herniation, you peel the muscle back a little bit so I can see this piece of bone here. And you can, again, make a small window in the bone with a burr, and through that window of bone, you can remove some of this ligament here on the side. This person has a disc herniation, which could also be removed. But if you take down some of this bone and ligament, you can open up the spinal canal so the nerves can get through freely. That's really a wonderful procedure. It's a go home the day of surgery, meaning it's an outpatient surgery, just like a discectomy. We limit your bending, lifting, twisting after surgery, but otherwise, once you're finished with the recovery, you can go back to doing whatever you want. In rare occasions for stenosis, and that's really only if it's accompanied by another condition called spondylolisthesis, we'll have to do some a bigger surgery. Now, a condition that accompanies lumbar stenosis frequently is called spondylolisthesis, which is a fancy word for you have a slip. So meaning one vertebral body is slipped forward on the other, and I'll show you some pictures. This can occur either in a degenerative fashion, and I'll show you some pictures of that, or in what's called a traumatic or isthmic fashion. So degenerative spondylolisthesis occurs because the joints in the back here hold the one vertebral body to the other. So this is L5 and that's S1. So the joints here hold this spine together. Over time, the joints are held at a certain amount of tension because of the cartilage within them. As those joints get more arthritic, the cartilage wears down and the joint becomes a little more sloppy. And so as that occurs, there's now more play in the joint, and so the vertebral body that articulates with the body below can start to slip forward because that joint is no longer helping to hold it in place. There's another condition called what's an isthmic spondylolisthesis, or a pars defect, and this usually is the result of either a congenital defect and or some micro trauma or major trauma, usually when people are much younger. And so it tends not to manifest till people are much older. I do see this in children sometimes, and it's almost always treated just with bracing and time. But most of the time, people will have what's called a pars defect or spondylolysis that occurred generally when they were young, in their 20s, teens, whether they had a trauma, or if I'll see it in football players or gymnasts or dancers or volleyball players. And basically you get an overuse injury or a stress fracture at the back of the spine. And it's in a piece of bone called the pars that connects this joint to this joint. And so that means the front of the spine now is no longer connected to the back of the spine because this piece of bone that connects them. And as that gets looser, the whole spine can start to shift forward. The way that spondylolisthesis and the accompanying stenosis tends to occur is with a spondylolisthesis, if it's degenerative, it's one vertebral body moving forward on the other. And because your nerves that descend through the canal are running through a tube, each piece of the spine has a tube that is a portion of its anatomy. And as it slips forward, those tubes misalign and the nerves get pinched in there. With a degenerative spondylolisthesis, usually people have pretty severe central stenosis, sometimes foraminal stenosis, meaning narrowing of the nerve holes on the side. With what's called this isthmic or traumatic spondylolisthesis, as that piece of bone degenerates and or is broken and the fibrous tissue that holds it together loosens, the tube in the front is not connected to the back, so the tube doesn't narrow the spine. But what happens is the nerve hole on the side, which is called the foramen, gets pulled forward into this oblong shape. So the normal nerve hole has an appearance like this. As that piece of bone gaps here and the spine moves forward, that tube gets elongated and the nerve gets trapped within there, causing pretty severe leg pain. Well, so what do we do for spondylolisthesis? And I'll show you some pictures. It's the same thing. And so we start really with physical therapy. The manifestations of lumbar stenosis with spondylolisthesis can vary. With an isthmic and or degenerative spondylolisthesis, a lot of times people do have back pain. When you have the pars defect and there's motion, there's technically instability at that level, and so that causes pretty severe back pain. With a degenerative spondylolisthesis, it's the same. There's severe arthritis in the low back, and that vertebral body is slipping back and forth. And oftentimes it'll slip back when you lay down and slip forward when you stand up. That will cause pretty severe back pain. And then as the nerves get pinched, either as they slip forward in the canal or as it slips forward as the nerve holes exit, that can cause pretty severe pain that goes down the legs. The manifestations tend to be the same. Most people have more pain when they stand and walk. It usually tends to improve when they sit down and lean forward. Usually working on nerve glides, physical therapy to work on low back stretching, range of motion to work on core strengthening tends to be very effective. Chiropractic care is very effective for all these conditions as well. We always try a course of NSAIDs, and a lot of people say just a dose or two of Aleve a day can make them feel much better. Epidural steroid injections can really be effective for this condition. So you inject steroid either into the spinal canal at the level of the spondylolisthesis or in the nerve holes on the side, excuse me, can really be effective to relieve that pain. Now, you can have enough of a slip or significant enough pain that doesn't respond to these injections and or care, and most of that is the result of either severe slippage causing severe pinching of the nerves on the side or severe slippage causing severe pinching of the nerves in the middle. That's the time at which we discuss a surgical treatment. So this first picture here is an example of what's called the original, or what's called the isthmic spondylolisthesis, or the PARS defect. And this patient had a defect in the bony anatomy on the side. So this is S1 and L5. That's the joint on the left side, and the joint on the left side at L5S1. And that dark line through there is a defect in the bone, and that's inhibited the restraint of forward motion of this vertebral body on the other. And so that vertebral body is starting to slip forward. And as the disc degenerates, that causes that vertebral body to slip forward more and more over time. This patient had both severe back pain and leg pain and was unable to walk really unassisted at this point. There are times where you could have this condition and never know it. I met a gentleman who was in his 80s a couple of months ago who had a spine that looked very much like this. Didn't even know that they had it. And so this doesn't always require surgery, treatment, or anything. Sometimes it'll slip forward, and actually as the disc degenerates, a lot of times the spine will fuse itself. Because there's instability related to spondylolisthesis, whether this be from this PARS defect or as a degenerative, as we'll talk further, usually the motion preserving or decompression type procedures aren't as effective because you're trying to restore alignment and you're also trying to restore stability. So in this case, the alignment of this patient's off. You can see the trajectory of the spine should be like this, but instead it's like this and then slips forward and then it comes back. Well, that would make it really hard to stand up because the spine is trying to tip off the anterior aspect of that sacral body. And so it makes it really challenging to stand upright. In addition, the nerve pinching will also cause pretty severe pain as the patient extends because those nerves get additionally pinched as you extend your back. So the job here is not just to restore stability and open up nerve holes, but also to restore alignment. One of the reasons I always get x-rays of patients in a clinic is because I want to see what your spine looks like bearing weight. And this is that patient's spine. And your lumbar spine is lordotic, meaning it curves backwards. And as you lose lordosis, that pitches your body out front and is really an exhausting condition to have because as your body leans forward, you have to rely on your low back muscles all day long to hold you upright. And so one of the reasons people have back pain, especially with conditions like this, is now they're having to work overtime to keep their spine erect. So in this case, this patient really needed several things: restoration of anatomy to open up nerve holes or provide neural decompression, restore stability, and restore alignment. And so for this patient, we do what's called an interbody fusion, meaning I place a spacer in between the vertebral bodies. And by doing that, that allows me to both elevate the nerve holes by opening up opening up the disc space, restoring the anatomy by pulling the spondylolisthesis back, and restoring the alignment so that the spine has the natural lordotic curve. This is a patient that has a degenerative spondylolisthesis. And so you can see here, there's a kind of a stair step of the spine. This is S1, L5, 4, 3, 2, 1. And this is the MRI. And this is where the spine is slipped forward at these two levels, causing constriction of the canal at these levels. Well, just the decompression alone would cause instability. So if you try to take bone and ligament off the back, like you do for regular stenosis, you can actually make these slips worse. And so same thing when this patient had failed eventually injections, and really this patient was able to go for many years with injections, physical therapy, and NSAIDs, but unfortunately reached a point where those things were no longer effective and the pain became quite severe. In addition, this patient's alignment is off because each portion of the vertebral body is pitching forward and therefore leaning this patient forward and making it difficult to stand. And then the stenosis itself makes it very difficult to extend your back because as you try to stand erect, it causes pain down the leg. So for this, we performed an alignment procedure where I did a procedure where I went through the side, made a small incision in the side. I can dissect through the muscles on the side and actually deploy a retractor down to the spine and put these retractors or put these spacers in from the side. That allows us to open up the anatomy, reduce the slip, and then I can place these rods and screws percutaneously through the skin. This is a very minimally invasive procedure that I use to restore anatomy for this. It actually is much easier than sort of traditional open methods for surgery, which are effective and we still have to use sometimes. But unfortunately, or not unfortunately, but fortunately, we have solutions that allow us to treat these conditions in what's called a minimally invasive fashion, where we can use smaller incisions, we can use anatomical planes, and we can go through portals that allow us to place spacers and or screws in such a way that allows faster recovery. Same thing for this patient. I was able to go through the patient's abdomen, which sounds terrible, but believe it or not, if you make a small incision in the abdomen and go around the rectus muscles, I have a general surgeon help me get there, you can move the abdominal contents aside and then you can see the front of the spine. By placing a spacer that way, that spacer has done all the work, has restored alignment, has restored neural anatomy, has reduced the slip, and same as before, I can make small incisions in the back and place the screws basically through muscular planes rather than stripping all the muscle off the back. And this allows for a really nice, fast recovery. The last condition we'll talk about is called adult degenerative scoliosis. This is actually very common. It's something that people are often surprised about when they see me in clinic because they have back pain and I get an x-ray and they have a moderate to sometimes big curve. And most people didn't know they have it. And adult degenerative scoliosis is both a curve in the frontal plane, meaning like you look at me and I'm curved this way, and it's also a pitch forward or what we call a sagittal imbalance, meaning you're leaned forward, and that's the result of loss of disc height over time. This is a condition commonly associated with degenerative change that occurs asymmetrically. So as discs degenerate, they rarely do it symmetrically. And so what will happen is one side of the disc may degenerate more than the other. That causes compression on one side. That causes more loading on that side, including on the joints and into the disc, which then causes more degeneration on that side, which becomes this perpetuating cycle. And so what will happen is, say you get degeneration on this side, well then you now have to do this to keep your spine straight. Well, that will cause an additional curve at the bottom, which we call a compensatory curve. And so it becomes a self-perpetuating cycle. In addition, as we age and as degenerative scoliosis occurs, the disc gets lost. And so what will happen here, this is technically a degenerative scoliosis in the sense that there's a forward sagittal imbalance, but these discs have all lost height and lordosis is lost. So this person's spine is straighter than it should be. It should be more curved. It should be this curved. It should be this curved, where the curve goes backwards and the head is above the pelvis. What occurs with degenerative scoliosis is people get pitched out forward and have a really difficult time standing up. That's, as we discussed before with low back pain from stenosis, this is exhausting. So you spend all day long trying to keep your body upright, and those compensatory muscles get exhausted pretty rapidly. You'll find people often end up needing canes, needing walkers. They really have a difficult time standing erect. Sometimes they have what's called a coronal imbalance where the head will be off to the side. That's in pretty extreme situations. While this is very common, it's very uncommonly so symptomatic that it needs even anything done. And like I said, frequently people who see me for what's more of an acute back pain than chronic back pain will find that they have some kind of adult degenerative scoliosis. And what I always tell them is that in and of itself, a curve is nothing to worry about. So if you have a curve in your spine and it doesn't cause symptoms, it doesn't matter. It's not going to do anything to harm you. Curves can progress over time, but also some people have some intrinsic curve to their spine that they really didn't know that they had. A curve that has no symptoms doesn't need any treatment at all. Adult degenerative scoliosis that is symptomatic tends to be symptomatic both because of the positive sagittal balance that I described and arthritis of the joints. And so those get treated the way we discussed before, which was you really work on physical therapy to help people maintain an erect posture. You work on NSAIDs to treat the associated arthritis of the low back, as well as the degenerative disc disease that occurs. Also, chiropractic care works very well. This can be associated with osteoporosis because as the bones get less dense, they can compress. So I always recommend to anyone who has osteoporosis to get it treated, especially if it's in the spine. This is rarely a surgical condition. I did bring this up because there are surgical treatments for profound and severe adult degenerative scoliosis, but those patients that require degenerative and large surgery are few and far between. And I would say well over 95% of the patients that I see in my clinic that have some kind of adult degenerative scoliosis don't get surgery at all. There are times when it's accompanied by things like stenosis because as those discs degenerate, you can still get pinching in the canal. So you can have more than one thing. Adult degenerative scoliosis can beget pinching of the nerve holes as they exit or pinching of the nerve holes as they descend. And so for those patients, we do recommend steroid injections, a course of steroids, and definitely physical therapy and NSAIDs. And then for the facet arthritis that we discussed earlier, the radiofrequency ablation is an excellent procedure to relieve the low back pain associated with the arthritis. In rare occasions, people do need a surgery for this. These tend to be larger reconstructive surgeries for profound scoliosis, but a lot of times if someone has adult degenerative scoliosis, but they have a different origin, say a small spondylolisthesis or stenosis, it doesn't always require a massive surgery. You can just treat the underlying or the small symptomatic segment and just ignore the rest of the curve. That's all that I have for everybody today. I thank everyone for coming out today, or watching us virtually, I should say. If you have any questions, I think they're going to provide my clinic number or a way to reach out to us if you want to come in and speak with us or meet with me. And it was an absolute pleasure to talk to you today. Thank you.
Thank you so much, Dr. Harper. That was very informational, and we want to remind our audience that now is the time to ask your short general question in the chat box below the video on your screen. We have received some already, and in no particular order, we're just going to start going through some of those. Can you explain what NSAIDs means?
Oh, sure. It's a non-steroidal anti-inflammatory drug. So ibuprofen, Aleve, meloxicam, Celebrex, these are anti-inflammatory medications.
Okay. How long after starting osteoporosis drugs can a person have a spinal fusion?
It depends on the medication that you're taking and what your DEXA scan shows. So frequently we like people to be treated for 3 to 6 months before having a spinal surgery, but it really depends on the medication that you're on. But usually, and it also depends on what your DEXA score was before you started treatment. You don't always have to have a follow-up DEXA scan. If you're on an anabolic, sometimes you can shorten that treatment scale. If you're on one of the bisphosphonates, sometimes it was still like 6 months to a year.
Okay. Can a person safely lift weights to combat osteoporosis with existing spinal and cervical stenosis and herniated discs?
The answer is it depends. I'd have to look and see how, it would matter how severe your cervical stenosis is. If it's severe and needs treatment, then it might need to be treated before you could safely lift weights. If you're just lifting light weight to help increase your bone mineral density as well as your muscle mass overall, and your osteoporosis is being treated, usually very lightweight treatment is fine.
There were a few questions about post-surgical nerve pain. For example, this person had a second lumbar spinal fusion a couple weeks ago. They have nerve pain in their hips, groin, and thighs. Is that common? Can it resolve? What can they do to help it?
It can be very common after a spine surgery. It depends on what the preoperative symptoms were and if the symptoms occurred before or after the surgery. Sometimes if things have been compressed and required a surgery or even a second surgery, the nerves can be pretty irritated and angry after a surgery or even before a surgery. So a lot of times, some of the nerve pain that you were treating with the surgery itself can take some time to quell. Then often we'll get some follow-up imaging to take a look and see if everything looks okay. And then sometimes you can even do steroid injections at a certain point once we've moved past the safe phase of a surgery. But usually in the first couple of weeks, you can often expect to have some residual numbness, tingling, and or pain, especially if those were the symptoms you were having before surgery.
Okay. Is there anything being developed to help with degenerative disc disease?
There are, yes. So there are the various treatments are this. It's either steroids and therapy and time and NSAIDs. There are some experimental treatments that I can't speak to about whether they work or not, which include like disc injections and things, none of which have been proven to work. There are lumbar disc replacements. So for usually younger people with severe degenerative disc disease that is not responsive to conservative treatment and is severe and horrific, you can actually, instead of fusing the spine, put a lumbar disc replacement in there. And that actually helps with the symptoms of degenerative disc disease because you're taking the disc out. And then for folks that are a little older with facet arthritis, degenerative disc disease, if it's usually associated with nerve symptoms, can be treated with a fusion surgery. But degenerative disc disease in and of itself is almost 99.9% of the time a non-operative treatment, a non-operative condition.
Okay, thank you. This person has some back pain because they had a tree branch hit their lower back. It was over a year ago. They didn't have imaging. They were told it might take 12 weeks to kind of settle down. They still have a little tightness in their lower back, like when they're bending down. Any suggestions on just what they can do to relieve that last lingering bit of pain?
Come see me and we'll get some images and I'll take a look at you and we'll see what we can do.
Okay. Is there any alternative to steroid injections that would give the same results?
That's a good question. Oral steroids or time. But unfortunately, steroid injections are so effective to treat the pain of an acute disc herniation or stenosis. There aren't a lot of great specific alternatives than that, other than people can take NSAIDs or try anti-inflammatory foods or things. I'll just say I haven't seen anything as effective thus far.
This person has testicular pain. It's associated with their back pain. One doctor said it was a tight psoas muscle. What can be done?
That would require an exam and some imaging to see, to know, because there are spinal sources of testicular pain as long as you've ruled out the other causes. Things like the spondylolisthesis that we discussed or stenosis in the low back can cause testicular pain. Before I can give you a specific recommendation, I'd have to kind of see you and take some pictures and work you up from there.
Okay, thank you. What advice would you give to people lifting weights for strength training, and how about to runners?
So for weights, the one thing I recommend is never lift or hold weight out in front of your body. So bent over rows, I tend to tell people to avoid lifting weights above your head while you're seated. While you're standing, it's okay. And the reason is you want your spine to be in lordosis or back as you bend forward and lift weight above your head, you put pressure on the front of your discs. I also tell people to avoid squats and deadlifts. That said, if you're lifting weights, dumbbell activities, body weight exercises are all wonderful ways to build strength. And the more strength that you build in your core and just your muscle mass, the better your back is going to be. And this is especially true, especially for postmenopausal women who really need to work on building bone mineral density and muscle mass. For runners specifically, I would just say it's mostly good form and good shoes. And then take rest days.
Okay. Just 1 second. Can pain in my hip socket be caused by a back problem?
It can. Yeah. So groin pain can either be joint arthritis, it can be psoas tendonitis, or it can be pinching from usually like around L3-4 can cause pain in the groin.
Can you please discuss success rates associated with microdiscectomy?
It's one of the most successful things that we do. The risks of microdiscectomy are reherniation is the biggest risk. So that's about 15% of the time, depending on the size of the disc and the size of the hole in the back of the disc. There's also a risk of nerve injury or dural tear infection. Those are pretty low. The success rate, I guess, in most hands tends to be over 90%, because once you take the piece of disc off, as long as your symptoms haven't been going for too long. So the one caveat to this is people that have chronic disc herniations, and that means anything 6 months and over, those people do have a longer recovery after the surgery, to fix this, because nerves that have been pinched for a long time, this is kind of addressing that previous person who asked the question, is the longer you've had compression, the longer it takes for things to recover. So for longer term disc herniations that still have leg pain, surgery sometimes can be a slower, longer recovery. But I would say probably 95% of people that I do a discectomy on have almost immediate relief of all their leg pain. Usually it just like you'll get a zinger or two after that, but generally it's one of the most effective surgeries that we do.
Okay.
Like I said, I myself had one, and it was one of the best decisions I ever made.
It's good to know, especially personal experience. At the beginning of the lecture, you mentioned that smoking can cause or contribute to disc compression. Does that include cannabis?
That's a good question, and I don't know. Although I think smoking cannabis is generally not good for you. It's both the toxic byproducts of smoking as well as nicotine that are bad for your back. So the toxic byproducts of nicotine are bad for your arteries, and you have small capillaries that go to the discs themselves, and then nicotine also constricts those blood vessels. So it deprives your disc of nutrients, and so that causes degenerative disc disease. I don't know specifically about marijuana, although I know that there are also some of the very same additional health risks of arteries, heart, and lungs and things from smoking marijuana, just like there are from smoking cigarettes.
Okay. Is it okay to postpone surgery until as late as possible, or will aging interfere?
Not always. In fact, I usually tell people to postpone surgery as long as they can. So surgery is only for situations where you have so much pain that you cannot take it anymore, or if you have like instability or weakness or something that requires surgery a little earlier. But you can wait for as long as you want for surgery. And the people here in this community, are some of the healthiest people I've ever met. And so I've done surgery on people in their mid-80s who, back in Missouri, that person probably wouldn't have had a surgery. But here, the people that are 85 are as healthier than I am. And so we tend to go based on your overall health and how you are rather than your age itself. There are some things about aging that do make recovery from surgery and anesthesia harder. But I would say if you can delay things, it's frequently fine to delay things. And most of the time I tell people who come to my clinic who have a condition that might be surgical and they want to talk about surgery, I'll just say that most surgery is elective, meaning they never have to have surgery if they ever want, and they can wait as long as they want.
Okay. NSAIDs dangerous to use long-term? For example, how about Tylenol?
NSAIDs can be, with prolonged use, can be bad for your kidneys over time. Tylenol is actually, it's a different kind of medication. It's an analgesic, but not an NSAID. That one's processed by your liver. You can use Tylenol pretty safely, up to 3 grams a day, although less, unless you're a heavy drinker or take some other liver toxic medication. We do recommend shorter courses of NSAIDs over time because those can be hard on your kidneys. And then if you have any additional risk factors or take any medications that might affect your liver, to kind of limit the amount of Tylenol that you take.
Okay. A little bit of a specific one, but we'll try this one. Can an epidural injection in L5-S1 help performing pain?
Was it piriformis pain?
Yeah, maybe that.
It depends on what the if the piriformis pain is from stenosis at that level, it sure can. And like I said earlier, frequently people will be told when I see them in clinic they have piriformis syndrome and they actually had an L5-S1 disc herniation, because people will feel it right where the roundness of the buttocks meets the leg, that kind of cleft right there. A lot of times people have pain right across that cleft. And so it'll mimic piriformis syndrome. It won't fix piriformis pain in and of itself, but it'll fix piriformis-like pain, or can fix piriformis-like pain if it's related to compression at that level.
Can you clarify a prior answer, the one about squats? Should you avoid all squats or those with weights?
Those with weight. So yes, you can do split squats where you put one leg back on a bench and do it with body weight. So I do this because I've had a bad back. I don't do any of these exercises, so I don't recommend anything. I don't recommend caution that I don't employ myself in my everyday workouts, but body weight squats are okay. Single leg squats, like if you're sitting down and going down on one leg without weight, maybe with something underneath you, or what's called split squats, where you put one leg, I don't know if anybody can see me, but you put one leg up and you put one leg out and you kind of bend forward on one leg. Those can work. I usually recommend squats like if they're body weight. It's just that form is hard to do. The form is difficult, and it's difficult to do well by putting weight on your back.
Okay, thank you for that clarification. Can you please repeat the typical timeline for a herniated disc to calm down? They thought you might say 6 weeks after PT?
It's usually like 6 or 8 weeks. For most of them get better around 6 to 8 weeks. Some last longer than that. Some last forever. But I would say on average between 6 and 8 weeks with PT, sometimes with an injection. That's about the timeline when they tend to get better.
Okay. And can you talk about what to do for pain for sciatica?
It kind of depends on what the source is. So if it's related to the disc herniations or stenosis, like we talked about today, usually we start with physical therapy, rest and NSAIDs, heat or ice in the back, and then epidural steroid injections. But that would require just some imaging to find out where your sciatica, the origin of your sciatica. Usually we get an MRI just to take a look and see what nerves are being pinched or being squeezed, so we can be very specific about the injections. But it's the same general course of conservative treatment we really do for anybody, which is time, PT, rest, ice, NSAIDs, and then epidural injections.
Well, thank you very much for answering all of these and for the lecture, but we have come to the end of our time.